find that. Oops, share screen. And can you guys see that? Can you guys see this? See the case study?
Yes, we can.
Okay, so I'll make it a little bit bigger. Did it come bigger on your screen too?
Yes, it did.
Okay, so we have a 73-year-old married man, a retired railroad engineer. He goes to his internist and he's saying, whenever I try to do anything, I get so out of breath, I can't go on. I think I'm just getting older, but my wife told me I had to come see you about it. His resting SpO2 was 83%. Is that good?
No.
Okay, what else did you notice in the vignette, but up until this point gives you concern?
That he gets out of breath and he just can't continue.
Right, so he gets out of breath and he can't continue to move forward. What else? What about his occupation?
Railroad, environmental.
So he has an environmental factor that could be the reason why he's not breathing well, correct? All right, so he was sent to the local hospital got a chest x-ray, ABGs were done, and after resting 20 minutes on room air, he returned to the office. After evaluating the results, the physician told him he had severe emphysema and must start on continuous oxygen at 2 liters of oxygen or a 2-liter flow rate. He was prescribed HOMO2 or oxygen therapy. Pulse ox and ABG results were also on that prescription. So what is the rationale for putting him on 2 liters of oxygen?
With emphysema, you don't want to administer too much because they are stimulated to breathe based off of their oxygen levels.
Okay. Anyone else? Well, why start him on 2 liters? What in the vignette tells you he needs oxygen?
His SpO2 is 83, and we want to get it to 94 and above, or 95 and above.
Right. So, I mean, even if you have them at 92, you're at least happy with that. 92 to 94%. It's not the best of what you would look for in someone who doesn't have emphysema. However, for them, we don't need to have them all, cranked all the way up like we would expect a person who doesn't have COPD. Does that make sense? Yes. Because remember, their hypoxic drive is based on their oxygen levels. So their brain or their chemoreceptors is reading if the oxygen levels are high or low. So if we tank them up too high, then their breathing center is going to be like, oh, we have a good oxygen, so we're good. We don't need to breathe. And then the patient will stop breathing. Does that make sense? So it's reading their low oxygen levels. Okay. Anything else about why he needs to be on 2 liters? And I like the idea of starting them low, then going high. That way you have room to grow. So I like that. So what criteria do you feel, or what criteria need to be fulfilled for Medicare to pay for his home oxygen therapy? So this is kind of an outside of the box question, but it is one in practice that you would have to consider. What do you think would be the reason why we need to make sure we meet all the tick marks before we can get home oxygen? Anybody?
He has chronically low oxygenation.
Well, Medicare, any insurance, they want to have proof that this is needed. So based on the labs that he's received, what do you think would be appropriate to support the need for home O2?
As far as I know, usually doctor will have to submit what they call a CMN form to Medicare with the diagnosis code. And then Medicare will have to look at that and approve before they can cover the...
So when you want to have like your chest x-ray results, what they look like, your ABG results, what they look like, would that kind of not make sense? And your assessment of the patient, what you found, what actually you use for treatment. So all of those would be, rationales to show, okay, this is where his blood gas was on room air. This is what his blood gas is on, 2 liters of O2, and we want to have him breathing over here versus over there. Does that make sense? Y'all still thinking about it? Yeah.
Makes sense.
Based on most common cause of emphysema, what assessment regarding health behaviors is needed?
First, he has to stop, maybe change his occupation, what he does, because obviously the environment in being a railroad engineer is getting to him. So that, and then maybe the work is very stressful. So he needs a lot more rest, because as part of treatment, there's a lot of rest for activity balancing where, yes, a lot of rest. And so.
Okay. So we don't know all of the rest of his history yet, right? But he's a retired railroad engineer. So that damage has occurred over however many years he was at that job. It doesn't say that he smokes, but that would be another reason to or something to investigate. Because those are our most common causes regarding that. Assessment regarding his behaviors. I mean, they may have caught this earlier had he gone to the doctor sooner than later. So, he's chucked it up to he was getting older versus, actually I may be having a real problem. So what if he had a fever? Would you be concerned?
Yeah, for infection.
That'd be infection.
Right. So people with COPD have to get their flu shot and get that pneumonia shot. They are prone to, and they can develop colds. They can develop all types of things. But now this actually complicates their underlying disease process, and it becomes a medical emergency anytime there's any kind of stressor in their life, whether it's personal, professional, or health-wise. So all of those are going to be concerns because it's going to activate that system. Okay. So he has affirmed that he is a half a pack per day smoker for what? 50 years. So he's counseled on the smoking cessation. He agrees to stop smoking, but we all know the damage is done. He told CE his office would have a home equipment company call him to arrange the delivery and educate him on how to use it. So as a nurse working for the company, you are assigned to be his case manager. How would you prepare for the initial visit? Hey, doggy. So what are some things that you would be thinking about? So you have a 73-year-old gentleman, that's retired, now has home O2, and this is going to be a kind of like an image issue, because how many 73-year-old men you see walking around with a tank? Does that make sense? Family-wise, he may have some struggles having to now know that he has to tote this tank around, right? So he may not necessarily he may become more of an introvert than being an extrovert. He may not go out like he used to. So I would talk about the importance of that and making sure he had it. There's all different types of oxygen delivery systems. So if I was a home health nurse, I would look at thinking of one that could better support him and his needs. The importance of not smoking. Oxygen tanks are combustibles, and they can, we don't want to try to shoot darts or anything at them, and we don't want to turn them into missiles. So all of those things would be important things to talk about. How do you set it up? How do you calculate how long it's going, how much oxygen you have in the system? When should you contact the oxygen company to bring out new tanks? Does that make sense? So my neighbor's got a grandmother. I never heard of this, but she was melting candles and then remolding them. So that way she kind of saved when the candle got really low, then she would actually melt it and then try to remold it into another shape and then use the candle again. whatever. However, in doing so, she did have COPD, but the curtain in the room caught fire, and she was kind of in a confined space. So it was one way in and one way out. I think it had one window, and she almost blew their entire house up. So a good thing the tank didn't explode, but she was COPD, had been a smoker for many years, and this really didn't work out in her favor. She did survive the smoke inhalation and the burns, but she died about 3 months after. So those things are, really want to give them the education about that and how to manage it. So what would you address with both of them and their wife at the first visit? It would be no different than if you were seeing the patient in the hospital. What would you say?
What to expect.
Okay. How about when to call the doctor? Because they would need to have a pulse ox somewhere around there, besides just giving them the oxygen tank. How to measure things, how to know when things are getting worse. The one thing I didn't talk about was tubing that's associated with it. How to make sure you have enough to go. So all of that would be, and then find out what are their concerns. What concerns do you have that we can address? So what assessment do you need to do at each follow-up visit? So what will be your follow-up?
Continue to listen to the long sounds.
Yep.
You have a baseline. Normally when you listen the last time, and of course COPD is known by diminished sounds. So even though it's a progressive disease, sometimes there are, I would say, bronchitis, that exacerbations and all that. So listen to the long sounds. You look at the pulse ox as well. So those are things I'll check on every visit.
Okay, that's good. Anything else? So even though he's getting this oxygen tank, what other things, like from that article, could you do with him to help him with his condition?
I think medications.
Okay, medications. What else?
How to breathe. The best positions, like the orthopneic position, called the tripod, are teaching that as well. How to sit up as orthopneic position. Yes, are teaching that as well. The tripod.
What about exercises? Like exercises for his lungs.
Like breathing exercises, like with the spirometry.
I didn't hear that, Marky.
Breathing exercises with the.
Right. So remember in that article, it had all the different types of exercises that you can, you would encourage the patient to do. I think it was on, I'm pulling it out myself, page 50. Nutrition was part of it, how to eat, how to conserve energy, how to cluster care, pace yourself, your feet on the floor, lean your chest forward to facilitate your ability to breathe. So all of those different types of things, while you're shaving and brushing your teeth, then sit in a chair versus standing up. So things not to tire yourself out, but then other things to help promote, healing as they go through. So that's why that article is really good, because it actually helps the person, work through processes. So as you go through your care, find out if they've had any recent shortness of breath. Do they wake up in the middle of the night, short of breath or anything like that? If they lay completely flat down, do they have orthopnea? Does the medications work? Are there any side effects with the medications? So those would be all the different things that you would think about, asking or providing for your patient And again, he sat and he waited. So giving him tools of, when he should call the physician, the exercise training that he should do, like, bicycling, treadmill, those will all be some good exercises. I would not recommend, doing Insanity and P90X. That will probably take him out the game. But he can, walk for 20, 30 minutes, walk in the neighborhood or walk at the local track to start building up some endurance to help breathe better. And if he truly stops smoking, we're talking about smoking cessation. So we know that folks really do need some additional help like Chantix to help them, get over smoking. So some folks do quit cold turkey, but most people, they don't. I'm trying to see what else that article talked about from scratch. They could do some strengthening exercises, 5-minute warm up with stretching and flexibility, yoga. So all of those would be some good things to do. And then we also have talked to them about end of life decisions. Most people don't want to hear about that, but if it is a chronic disease that does scar the lungs, and at some point they will, fatigue out and not work as well. So there's always that possibility of, him getting to the point where he will end up dying. So we just want to make sure that we're honest about that process. All right. So the next time you go see him, he puts pores behind his ears. He explains that long oxygen tubing seems to take on a life of its own. It twists around, get caught under the doors, chairs, everything. It darn near rips the ears off my head. Now, does that sound like it's on too loose or too tight?
Too tight.
It's too. Oh.
Yeah, that's too tight. So what about the tubing though? So we probably want to, do a demonstration how to put the nasal cannula in. That's one thing we didn't talk about earlier. It's the proper way to apply nasal cannula. And then, maybe the tubing doesn't need to be as long, especially if it's getting caught up indoors. So maybe find a way to coil it. That would be some things that can help him. So you auscultate breath sounds and you detect the odor. Vicks Vapor Rub. When you question him about the Vicks, he tells you that he started to apply it and around his nose to prevent his nose from becoming dry and sore. So what specific teaching do you need to reinforce with this patient?
You don't want any petroleum-based products. Use a water-based, like a KY jelly
Right.
type thing.
Correct. I laugh at Vicks Vapor Rub because I know some people literally swear by it. Everything, Vicks fixes everything, no matter if it has the right, usage or not.
Put it on your feet and you'll quit coughing at night.
See? That's why I started laughing because I know people do it.
Why don't we want petroleum products near? Why not
Oxygen tank.
Products? Oxygen tank? Okay.
Yeah.
Oh, I never knew Vicks to be.
He asked why not have the petroleum. Why do we want to talk to him about the Vicks Vapor Rub? And you don't want to have petroleum-based products next to the oxygen tank or where oxygen is flowing. It'd be like smoking a cigarette.
Okay.
So after you have finished, his wife seems upset and she tells you he's still smoking a couple of cigarettes a day. How do you handle this situation?
If I may, smoking is a very difficult habit to kick. If it was very easy, nobody would be smoking right now. So it's to make the wife understand that it's quite difficult and then begin to explore alternatives to actual smoking, from patches, nicotine patches, to Chantix, to also all of those kind of equivalent of Alcohol Anonymous, where, because if everybody can refuse treatment, it is right to say, I want to stop smoking or I want to continue smoking. So just to offer alternatives and try and do your best to talk about it. But,
I mean, I would talk about, and all of those things of what you mentioned are correct. And I would also address the fact that, you know, this is only damaging your lungs more. It's not helping. So the impact it'll have on his lungs, his health condition, and also, you know, he is potentially setting himself up for, you know, the oxygen tank exploding. So smoking is difficult to overcome. And I think, you know, with the advent of such products like Chantix, because that has had some very good results. I know several individuals who have used it and has been successful. So, you know, he just really has to stick to the program. And every time you smoke a cigarette, it actually triggers a different or goes to a different portion of your brain, making it a lot more difficult for you to quit. So it just makes you hold on to it longer. So you visit your patient 2 weeks later, and he tells you that he has not smoked since your previous visit. He's upset, though, over an episode a week ago. He says he walked into the kitchen for a snack and became increasingly short of breath. So per your instructions, he removed the nasal cannula, tested the flow against his cheek, and felt no oxygen flowing from the catheter. He lacked the force and volume required to yell for help and was too short of breath to return to the living room to check his oxygen tank. He bent forward with his elbows on the countertop so he's in a tripod position and struggled to breathe. He became more frightened with each passing second, and his breathing became increasingly more difficult. A minute later, his wife found him and reconnected his O2 tubing. He sat at the table for 20 minutes before he could walk back to the living room. So does that sound like he's getting better or worse?
Worse.
Okay. So why did he assume the tripod position? What was the rationale for that?
It opens up. Yeah, okay, you go.
Go ahead.
The tripod position makes it a lot easier. Opens up the diaphragm a lot, so it allows for more movement of air in and out, especially to exhale. Yes, so he did it so he could breathe a little better.
Okay. So basically, we're going to try to help him facilitate his ability to breathe, right? That was the reason for is that not the reason for the tripod position, so the lungs can expand?
Yes.
Okay. All right. So his wife states that since the incident, he doesn't want her out of his sight. She asks you to talk some sense into him. She further elaborates, saying that since then, all he does is sit in a chair all day. He won't even get up to get himself a glass of water. I've got a bad hip, and this is all very hard on me. What will you do to help CE and his wife cope with his condition? What's changed in him now?
I think he's fearful as his condition is deteriorating.
Mm-hmm. Okay.
And I would say that he maybe even has some depression going on.
That's possible. Remember earlier on, I addressed some of the image needs and all of that, and now that he realized how short of breath he really is, and this is related to a condition and not necessarily of his age, you know, things are probably really starting to set in. But the other thing, is he helping himself or not by sitting in the chair all day?
No, he's not helping himself.
That's it's waiting for atelectasis is waiting to happen.
Right. So he's complicating his problem, which means that later on, you know, he's going to still have issues. We're not exercising those lungs and helping them build endurance if we're sitting in the seat. So we need to talk to him about, you know, activity intolerance and things that he can do.
However, I think we should also consider the fact that maybe is he able to move If he's not, and with his wife and her hip problems, maybe we should also consider a caregiver to come and assist. I think of that too.
Okay. So all of these are things that we can talk to them about, him, coping. I think that's the end of the case study.
Ma'am.
Yes.
Yes. You always talk about oxygen exploding, but in several places, oxygen tanks do not explode. They
Well,
only
it's not a
fill by.
combustible. I mean, it's not. It can be. It's not necessarily. It sets the condition for combustion to happen, is what I want to say.
Okay.
So it doesn't really explode, but it makes the conditions favorable for combustion to happen.
Yes,
Because that's what
Back to
fire
that,
needs
oxygen is one of the. I think there are 3 triangles of fire, and oxygen is one of them.
Yeah.
So I have used the word exploded, but because when I think of combustion, that's what I think of as an explosion that can happen. But basically, it just makes the conditions favorable for it to go down.
Be good. Have fun.
What was that? Oh, I think you were telling somebody else to be good.
Oh, I'm sorry.
That's okay. All right. So, let's see. Hold on. I hit the wrong button. Nope, that's not what I'm looking for. Give me a second. I don't need that one. I needed the stop sharing button to pop up. I'm like, come on, button. All right. So that was actually an emphysema patient. So that was good. So it's good to see that you all are trying to at least put those pieces together and kind of link them to what we've been talking about. With that being said, have anyone started looking at the acid-base material yet?
Yes.
Is it only one person? If not, I mean, we're going to talk about it Tuesday. So, I would say start thinking about what type of acid-base imbalance your patients, like your COPDs, would have. And then, what would be a medication that you could give your COPD patient or your asthma patient for that matter? We'll speak more of asthma. That what would be a long-term anti-inflammatory medication that you can give to also help them control their symptoms of asthma as well as the inflammation of asthma. That was the reason why I had you do the case, not the case study, but the crossword. I had to think of the word. So have you all looked at the therapeutic classes, etc.?
You give the albuterol.
Can you give okay, so is albuterol short or long acting?
Short acting.
It's short acting. So if you go to page 52 of that handout for the COPD, it gives you the medication. Even though it's for COPD, some of those are also utilized for asthma as well, like your albuterol that you mentioned, levalbuterol. The difference between the two is what?
The longevity?
Not longevity, but the side effects. They both do the same thing, which is bronchodilate. So know what your bronchodilators are. They're your beta-2, that remember the VCR that I talked about. The V was for vessels, alpha-1 receptor, causes vasoconstriction, pupillary dilation. C was for cardiac, works on the cardiac system, and that's your beta-1 receptor. So it increases heart rate and increases contractility of the heart. And then R was for respiratory. So That's your beta 2 receptor, and that works on bronchodilation and relaxation of smooth muscles. So even if you didn't know the medicine by name, at least learn the class or the receptor, or your albuterols usually have those metrols in them, like so levalbuterol, ROLs attached on the, so albuterol, levalbuterol, someterol. Does that make sense? The TEROLs at the end, the formoterol. So all of those will help you understand if you have a beta 2 agonist. You may not know exactly what it is per se, but you would at least know how its action would be. And then for your steroids, they usually have the ONEs, right? The ONs. So the fluticasone, dexamethasone, prednisone, it have those ONs at the end. So even if you're not familiar with all of the corticosteroids, if they have that ending, you at least know, oh, this is a steroid medicine, anti-inflammatory. So on that page is page 52 of that case study, of that article. It specifically speaks of short-acting, long-acting bronchodilators, anti-inflammatories, and then combinations. So we have a couple of meds that are combination, like your Advair is a combination med. There's a couple of others that are combinations. Symbicort, that's another combination med. I'm trying to see if there's another one. So long acting means that would be something that they would go home on. That would be their medicine that they would take on a routine basis. Short acting would be if the patient's having a flare up, then this is when you would want to give them that medication, like their multi-dose inhaler or maybe a nebulizer. And sometimes they may mix albuterol with ipratropium, which is Atrovent, and that way to potentiate the effects of bronchodilation. Does that make sense? Yay, nay, you're still thinking about it. Okay. So the other conditions was asthma. Any questions about asthma or bronchiolitis?
My question is, this will be B2 beta B2
So beta 2, the receptor?
Yeah. It seems to act differently on the heart than on the trachea, because it seems to B2 normally dilates. I don't understand. It dilates. Anyway, I'm just a little confused about it. About what it does.
So usually your beta 2 receptors are going to focus on the respiratory system. So if you're stimulating your beta 2 receptor, the action you should expect to happen is bronchodilation. That's its goal, is to dilate the bronchial tract and to relax the smooth muscles, which would basically be the bronchioles, correct?
Yeah.
Because there's no cartilage in the bronchioles. It stops at the, when you hit the terminal bronchioles and the respiratory bronchioles, all of that smooth muscle going into the alveoli. So when I'm talking about the receptors, if a medicine is designed to act on a specific receptor, that's the action that's going to be displayed. Does that make sense now? So even in the reason why I use the receptors is because it says short acting beta 2 agonist. Agonist means it's going to stimulate the receptor and it's actually going to cause a specific action. So the action that it causes when it's stimulated is bronchodilation and relaxation of the smooth muscles of the bronchial tract.
Okay. What I'm trying to find out is a bit confusing. When beta agonist, beta 2 blockers in the heart, it dilates.
That's different. That's your beta 1.
Okay.
So beta 1 primarily is for cardiac and that's going to increase your heart rate and increase contractility. So if you're taking a drug like metoprolol or atenolol, those medicines are beta blockers. So what it does is it reaches the beta 1 receptor and it fills it, blocking the action of beta 1. Therefore, it's not going to stimulate the receptor, it's going to inhibit the receptor, meaning it's an antagonist. Therefore, the heart rate won't go up, it'll actually go down, and your contractility will go down. And although this may seem counterintuitive, but for a heart patient to be on a beta blocker, you have to put it into perspective. Number one, we just had a heart that, you know, has had some demise. We don't really want it pumping really, really hard or working really hard. So what this medicine does is it slows down the heart rate, but it lessens the force of contraction so that the heart's not overworking itself. Does that make sense? So if you've already had a stressor to the heart, we don't want it thumping along. So for that one, we give the beta blocker to help still have good force of contraction, but we're just not increasing that force of contraction. And we're not increasing their heart rate, because if we do that, the heart's working harder, and then it's not emptying and filling appropriately, which means we can cause them to have another heart attack, because as you are not emptying and filling, then there's some blood that gets left behind. But when we talk to the cardiac and the perfusion part, that'll come back up.
Thank you.
Okay. But there's two different receptors. You do have an alpha 2 receptor, but it does more vasodilation. Okay. So that is a good question. So anything else on the gas exchange, bronchiolitis, or any of those, are we good?
We don't need to know all of those shift to the right, shift to the left, and all that, do we?
What shift?
I've seen it. The oxygen has always shift to the right and shift to the left. Want to know all of those.
What are you talking about? ABGs or what?
Yes.
Okay. For the arterial blood gases, the only thing that I'm concerned with right now, and what the level 2 team is concerned with right now, is can you read a blood gas? Right now, I'm not looking into whether or not you have compensated, uncompensated, because you're going to get that again in 4th semester. So can you just read a blood gas? Can you apply that acidosis, alkalosis, whether it's respiratory or metabolic, to conditions that we're discussing in this particular module? Does that make sense? So for this particular concept. So we have gas exchange, we have immunity, and then we have acid base. So in this module of concepts that we're discussing, can you apply those principles of acid base to that? I don't right now personally don't care about if the pH is going back towards normal, and that's too complicated. Let's learn how to read regular blood gases on a simplistic level and then build from there. So what should happen in clinical with your respective clinical faculty, then they should, when you have those patients, okay, so they could ask you those questions. If he was or she was compensating, what would you expect? But for the nature of the test, and really for your knowledge base at this point, it's the KIS principle. Let's just keep it simple. Okay. Oh, you're back there celebrating. That's hilarious.
Simple is good. Simple is very good.
I mean, honestly, if you've never been exposed to it, it doesn't make sense. And on average, we may have a handful of people that may work in the hospital setting for which they may deal with blood gases or come across it and have to interpret. But that is not that's not the majority. It's the minority. So we have to look at, to keep all things fair and within perspective. And as a level 2 student, I don't think just the fact trying to remember what goes up and down is going to be enough. So that part you're already going to be sweating bullets on. So let's just keep things into perspective. Okay. Not that, trying to make the test hard or anything, but just speaking on the fact that it's always difficult to learn blood gases. It's another line of thinking. All right. So are we good with that? And then wasn't there, I think pneumonia comes up with immunity. So I think in here we just had asthma, bronchiolitis, COPD. Those were our 3 exemplars, and aspiration pneumonia, but we can cover that either way. So aspiration, I think you guys pretty much understand how it happens, that we have acids or toxins now in the lung, in the bronchial tract. The inflammatory process starts, bacteria starts to brew, and now that person has pneumonia from those products. Would that make sense? Or does that sound like where we are on that process? Maybe. All right. So did we take a look at peak flow meters and so forth and so on?
No.
Okay. So remember, we always assess before we give anything, correct? So if you have a patient that's, having signs and symptoms of, of asthma or an asthmatic attack, and you auscultate breath sounds, you get your SATs and all of that. If there's any other assessment tools that you can utilize or to check before you start calling out the cavalry, then, just make sure, because I talked about that the last lecture on how to read questions, looking at basic life needs and making sure we follow the nursing process and we assess and before we start trying to do an intervention or evaluate an intervention. Okay. If your patient is confused, what 2 conditions, and they're an elderly patient?
Infection.
Guys.
In the morning.
Right. They're going to you should be looking at an infectious process of some sort that they would have, right? Okay. So, if a person, is confused, then I would probably, and they're on oxygen therapy, what should you do before you call the doctor? Especially if it's someone that has respiratory issues.
Assess the lung sounds and the breathing sounds and oxygen levels.
Your pulse ox and all of that. Okay.
Yep.
What if your patient's coughing up phlegm? What should you ask them? Even if it is a patient who normally coughs up phlegm.
What color?
The color is going to, that's important because why? It may not be their main condition. It may be a secondary infection that they're dealing with. So, other things, if your patient has, we know if they have aspiration pneumonia, they're going to actually have antibiotics, correct?
Mm-hmm.
And then we talked about all the different medications that could be used for aspiration pneumonia. So, what would be a good position, especially if they have an alteration in consciousness, to put them in?
Semi-Fowler.
Or what? Semi-Fowlers?
Mm-hmm.
So what if they vomited? Then what? If they were in a semi-Fowler's position?
Put them on the side, as in to the
Okay,
side.
so your unconscious people you want to have on the side, because that way if they do vomit, it will already, you can let gravity work for you. So that way you can get rid of all, they don't choke on it or it doesn't go down the trachea. So that would be the appropriate thing to do at that time, or at least for them. Let's see. So if someone has bronchoconstriction, what does bronchoconstriction really mean?
Closure in the bronchioles, so it's limiting airflow. And
So basically you have a decrease in airway flow. Okay. So is the airway getting bigger or smaller?
Smaller.
It's getting smaller. All right. What is the main cause of bronchiolitis?
like smoking, environmental factors.
And what else? This is bronchiolitis.
Is that RSV?
That'll be RSV. So if your baby comes in and you suspect that they have RSV, what's the first thing you should do?
Put them in contact isolation.
That's right, contact and droplet isolation. So that should be the first thing to prevent the spread of the RSV because it is contagious. All right. So what would be the care for those little PD pods with bronchiolitis? So based on Ms. Pritchett's lecture, how would you care for your bronchiolitis patient?
So hand hygiene, making sure you're not spreading germs with beyond like the isolation precautions, and then like medications like Synergist.
Okay.
And I know the book Hockenberry mentioned an antiviral,
Ribavirin.
Yeah.
Okay. Anything else?
Provide like enough time for them to get some sleep and rest. Same thing with the parents, since the patient's going to be experiencing some respiratory problems. This might be like a very anxious time for them. So care for the parents as well.
Right. So don't negate the parents because that, that can get kind of funky. So you do want to make sure you're including them. Okay. Anything else?
Replace the fluids.
Okay. So should you just give babies a bunch of fluid? How do you monitor how much fluid you give a baby anyway? You just give it to them. Here, baby, take this.
No.
Okay, someone said IV. So explain to me how you would give that IV.
Well, I mean, when it comes to, if it's something that they're going to consume, like with their diet, incorporate foods or drinks and fluids that maybe they like to help encourage fluid intake. So like popsicles or juices.
Mm-hmm. Okay. So what about, someone did say IV, so I want to go back to that one for just a second. So if you're going to give it to them IV, then what is your responsibility to that?
Monitor patency.
Okay. What else?
Monitoring how much you're giving them and how much they're urinating.
So how should you give an infant or a pediatric patient IV? And I know you're like, you're still on this? Yes.
I don't know the answer.
Okay. So we just don't put an IV in a baby and just let it drip, 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 drip. We basically, we give the baby the IV, and if they're infants, we're going to give them 10 milliliters per kilogram. So that's the first thing we're going to do. We're going to give them 10 liters per kilogram. If it's an adult or larger size kiddo, so school age and above, then we can look at giving them 20 mils per kilo. And that would go all the way even for an adult. So if you're a 70 kilo adult, then they need to give you IV fluids, depending on your situation, so they don't give you too much fluid, then they're going to give you about 20 mils per kg. So it's very imperative that you don't free-for-all an IV on a PD pod. So some systems use Baratrol sets. So basically, if you need to give the baby, say, 60 mLs of fluid, then you're only going to put 60 mLs in this little chamber, like a cylindrical chamber, and it has a little Rolodol at the bottom of it. And then once that's done, it's done to prevent the baby from having volume overload. That would be very easy to do. Some have the little IV pumps that you see around there that, you know, that you would give your patient, etc. So therefore, you know, with that process, then you would have, well, I want to say with that process, you would monitor it through the IV pump, but you would only set the volume to be delivered and nothing more, or for that matter, nor nothing less. So just keep in mind with kiddos and elderly that IV fluid infusions really need to be monitored tightly. Don't count on somebody else paying it any attention. That means you need to make sure you're paying it some attention. Does that make sense? Yeah. Okay. So, you know, just identify, you know, how you would do that. But that would just, you know, those are things you can do with your bronchiolitis patient. If they need fluids, then just make sure we're just not giving them, you know, all kinds of fluids. And we're just letting it run in and we're not really paying attention. So you need to set limits so that way you don't get caught literally with your pants down, so to speak.
You mentioned about 10 ml per kilogram. Is that per day or per hour? 10 ml per kilogram per hour?
That's total.
Total in
if you're giving them fluids, that you know, that would be all of what they would need, 10 mils per kg. And then you would monitor to see how the patient responded before you gave the next.
Okay.
So you wouldn't anticipate that you would need to give more without checking, is what I'm basically saying. Does that make sense?
Yep. Thank you.
Okay. Go ahead. I didn't hear that. Oh, okay. Maybe that was my question. Let's see what else before we leave that section. So we just want to make sure they're hydrated. We're gonna get them to rest. We're gonna check SATs. You know, all those things that we've already talked about. Keep them in a droplet precaution.
What about nebulize?
Well, if that's part of their order to receive nebulized treatments, which they will, breathing treatments, then yeah. Which it should be. So now I'm gonna shift gears. Just we're still gonna be a little bit on gas exchange, and then kind of working our way into immunity. So, you know, I did the whole big thing on pneumonia, right? And what's all entailed with your patients with pneumonia, the germs, you know, whether they have a prior infection, whether they're young or old. Usually kiddos get more of a viral pneumonia starting with an upper respiratory infection. And then, you know, they can develop bacterial pneumonia. Your elderly, they're going to have a bacterial pneumonia, so your adult patients will have that. If they're immunocompromised, they're on autoimmune meds or HIV or anything like that, they run the risk of getting fungal pneumonia. So all of those things are potentials that can happen to them. Right? Do you all remember that from lecture? Yay, maybe. Thinking about it.
I want to get in.
Okay, so, you know, we should know what our signs and symptoms are related to pneumonia. Pleuritic chest pain, they'll have a cough. We want to ask them about the color of their sputum. If they have any neurologic changes, especially for your elderly, right, with fatigue. And will they have a fever, elderly? Or would they be afebrile?
They'll be afebrile.
They're going to be afebrile. So that whole process of the alteration of mental status should literally come into fruition or should mean something. So let's see. All right. If they're an adult patient, not elderly, then they could have a fever. Their breath sounds will be abnormal, right? Oxygen sats can be less than 90. or it may be about 92 that we may need to consider some supplemental oxygen. And then they may exhibit signs and symptoms of like malaise and activity intolerance. Those are some additional things that they will present with. So we want to make sure we're checking breath sounds, and we could expect to hear either coarse crackles, rhonchi, or bronchial breath sounds that we would normally hear in the trachea, but we're actually now hearing them in the lungs. Then I talked about some assessment tools that you could utilize to determine whether or not they have pneumonia, like the tactile femotus exam that you can do. So that would be, you know, another test that you can institute to help you determine if your patient does have pneumonia. Let's see. Other things we want to monitor is respirations, the heart rate, oxygen stats, the vital signs, checking skin color, making sure they don't have any cyanosis or circummoral cyanosis or anything like that. ABG, sputum cultures, infection is needed, and then make sure we do have an order for some type of breathing treatment. We want to, do they want to drink 1 liter a day if they have pneumonia?
3 liters a day.
Huh? How much fluid do we want to give them?
3 liters a day.
2 to 3 liters.
So they need 2 to 3 liters. 2 to 3 liters of fluid. So if they're immobile, then we need to make sure we're turning them. We need to make sure that we're keeping their head of bed elevated, right? Give them their vaccines, making sure it's up to date, flu shot, talk about smoking, hand hygiene, incentive spirometry for patients that are admitted, right? Remember that? And then we have all the different types of antibiotics, from miscellaneous to macrolides to tetracyclines to fluoroquinolones to cephalosporins, all the way down to Pengine. All of those are potential medications for them to receive. Yep, remember that? Maybe thinking about it still.
Yes.
Okay. Any questions about the pneumonia? Okay. So you know the 3 C's for the TE fistula that you need to monitor for?
The 3 C's you said?
Uh-huh. Like in cat.
Well, I know circulation would be one.
Okay. Usually the babies will be coughing, choking, or have cyanosis. Those are your signs of a TE fistula. And there's various types of TE fistula. But the 3 C's that you would be looking for is choking, coughing, and cyanosis.
Yes.
So we want to make sure that we keep their head elevated. We don't give them anything by mouth, right?
No.
Because we don't know where it's going.
This is for what disease process?
For your TE fistula.
Oh, okay.
It's still part of gas exchange. Okay. I'm gonna slide on over now to immunity, if that's okay with you guys, because I don't hear any burning questions related to that. So I think we're.
Is the only way to treat it is surgery?
Yep. I mean, if you hang on one second, I just had it up here. Oh, let me find it again. So,
Will they ask us specific questions on the surgeries that they need to have for that?
I would feel hard pressed to say that they would, only because there's. I'm getting ready to show you. Let me share the screen. Let me find it. All right, there. Share screen. So, so here's a little, I don't know what they call these little things, but this popped up on my phone that, and along with things like hyperkalemia and all of that, I get those every now and again that pop up on my phone. But this one popped up, the tracheoesophageal fistula. So your three things you assess for choking, coughing, and cyanosis, right? And then here's all the different types of TE fistulas. So at this level, I would rather be more focused on you knowing that there is a TE fistula and that it exists, because the surgery is going to be dependent on the type. Does that make sense?
Yeah.
Okay. So this one here was from nursetips.com, but trying to ask you which surgery this would be, I think would be kind of counterintuitive, counterproductive in my opinion.
Okay.
Okay. But that is a good question. So I like that. All right, so we did a case study on UTI in class. Ms. Pritchard did, I think, OM and tonsillitis. And let's see here. Hold on. All right, so we're going to do this one. I don't know if it's on that.
Did you say tonsillitis?
Tonsillitis,
Otitis media.
Otitis media, yeah.
All right, so I'm going to share my screen again. So this is one we didn't get to. So here we have Lucas, he's a 17-year-old high school student who has an ankle inversion injury during practice. So swelling over the left lateral malleus, pain at the site of injury, limited weight bearing capability. The coach wrapped the left ankle with an elastic bandage, aka ace bandage, put ice over the area, elevated his leg. So when his mother arrived to pick him up from practice, she took him to the local ED. So at the ED, they found significant swelling, redness, and warmth over the left lateral malleus. He has full range of motion of the left ankle joint and the joint stable, but he complains of throbbing pain at the site, and he rates pain at a 4 on a scale of 1 to 10. Toes are warm and pink, wrist capillary refill, pedal pulses are present and strong, and sensation of left foot is normal. The x-ray shows no fracture. So first degree or mild sprain of the left ankle, they prescribed rice. For Lucas, the left ankle, they gave him acetaminophen or ibuprofen for pain. So what is a first degree sprain?
No muscle upgrade is
So in order for them to ask you this, they would be expecting you to know the difference between a first and second and third degree sprain. Right? So anybody look at the ankle sprain material yet?
No, I didn't.
First degree sprain is it's just like a mild stretching of the ligaments. The pain is really mild and just a little dysfunction at the tissue spots. Not too much swelling.
Okay. So it's basically a mild sprain. The function's not impaired. Okay. So we have tears of the ligament
No tears.
of the joint, but the joint function is still good.
Just stretching.
Okay. So correlate the signs and symptoms that he's experiencing with the inflammatory response of to his injury. So what things result when the inflammatory response is activated?
What was the question?
Right there on the screen. Correlate the signs and symptoms that Lucas is experiencing with the inflammatory response.
Okay, warmth, swelling, and pain.
So redness, warmth,
Warmth, swelling, and pain.
swelling, and pain. Okay. So the blood flow increases to the site that causes warmth and redness. Blood vessels leak fluid into the tissue of the site, so that's why we get edema. White blood cells migrate to the area. Increased nerve sensitivity, so pain and decreased joint mobility results from the ligament damage and edema of the tissue at the injury site. So this goes, if you go back and look at like when those histamines are released, what happens? So what happens in the inflammatory response? And pretty much it's spelled out for you right here. So this is why those signs and symptoms are what he's displaying. What is RICE and what is the rationale for each intervention?
The rest ice, elevation.
All right, so rest, ice, compression, which is ACE bandage, and elevation. So what we tell them to rest to allow the ligaments to heal. So I'll give you that one. What else? Why do we give them ice?
Decrease the inflammation.
We give them the ice to decrease inflammation. Why do we do compression?
To keep the swelling down.
All right. So we give the rest so that the ligaments can heal, prevent further injury. Ice should be 24 to 48 hours after the injury to stop the swelling. ACE bandage decreases the edema at the site of the injury and decrease the pain of movement. And then elevation, what are we doing that for?
To raise it up heart.
Venous return and reduce the
Decrease
edema.
edema at the injury site. How is the collaborative care for ankle sprain similar and different than the collaborative care, oops, hold on, for an ankle fracture? Sorry about that. My mouse is in the wrong spot.
So for a fracture, there's something that's similar. You also want to rest it. You also want to ice it.
Mm-hmm. So if they have a fracture, we're still going to do RICE.
Mm-hmm.
The difference is on the C part, wouldn't it? They may have a cast or a boot or something different, but it's still going to try to stabilize it to prevent pain with movement. Crutches. So you would still do RICE and pain management with oral analgesics. So depending on the degree of the sprain and the stability of the ankle joint, the splint or a brace may be required. The ankle fracture is immobilized with either a cast or bracing material. And it's important to do neurovascular checks. What are neurovascular checks?
Checking for the sensation. Also, if there's like pure perfusion with checking pulses.
Okay.
Yeah, making sure that there's no occlusion of any of the veins or the arteries.
Okay. So we're going to check for pulse, motion, and sensation. So we're going to, we can blanch the toe and see if capillary refill comes back with less than 2 seconds, right? We can have the patient wiggle their toes. We can, touch the toe or different toe and ask them, hey, what toe am I touching? Make sure they're not looking when you do it so that way you can get true results. So that's pretty much the difference there. But they'll probably be on, probably with a sprain, you may take like some ibuprofen. Whereas with a fracture, you may be on some Nocor. So, or hydrocodone, whatever you want to call it, it's all the same. I think that was it for that one. Just a short one. All right. So tell me a little bit about cellulitis and osteomyelitis. Those are the two that we really did not cover, but hopefully you've been reading and you've been looking at what types of nutrition to provide for those to help with healing, and how are patients more prone to get osteomyelitis, which is an infection where?
In the bone tissue.
So in the bone marrow, right? So it's inflammation of the bone tissue caused by an infectious agent. What's your infectious agent?
Staph, usually, and strep.
Staph and strep are your two causative agents. How do we diagnose it?
Culture.
Culture, okay. Usually the patient will have a wound, and commonly you can see this in your diabetic patients or your patients that have peripheral vascular disease. So we already know if they have diabetes, they're going to have delayed wound healing, correct?
Yeah.
Okay. So usually some signs and symptoms would be pain. They'll have heat. They'll have edema, fever. They may have malaise. And this problem could have been happening over 2 weeks or so before they actually realize what's going on, right? What kind of laboratory test would be applicable?
Culture and sensitivity, any kind of swab culture of the wound.
Okay, so culture and sensitivity of the wound. But what about your blood test?
CBC, complete blood test. That's the elevation of the white blood, WBCs.
Okay, so WBCs. What's an elevated WBC?
Over
11.
So over 10,000. A WBC should be between 5 and 10K, right?
Yes.
So anything over that, you'd have elevated blood cells. You can also have elevated granulocytes that may not even cause the white blood cell to go up, but that's something hopefully you will be seeing in clinical. The two things that are inflammatory markers are your SED rate and your C-reactive protein. They're usually elevated when the person has osteomyelitis.
Say that again, sorry.
Your SED rate, the ESR from the hematology. Okay. So then you'd have to order that one with that differential, CBC with diff, and then your C-reactive protein. So you may see that labeled CRP. Your procalcitonin levels for diagnosis or follow-up may also be given. So we've already talked about other cultures and things. They may do diagnostic tests, CT scan or an ultrasound or a nuclear medicine test to actually see what kind of changes may be going on with the bone. But that wound culture will definitely identify which one of those bacteria exists. Okay. So we want to make sure that, for those patients, They'll receive treatment there. They may go home with an IV in their arm or anything like that. So we want to make sure that we're talking about that component and how to assess the IV, making sure that it's patent, making sure how to look for infiltration, the cleaning the site and all of those things. What about nutrition? From a nutritional standpoint, what type of nutrition would you think would be appropriate for, to make sure that they have, according to your textbook?
High protein.
What was that?
High protein.
High protein. Anything else besides high protein?
High vitamin C, that helps with tissue.
I didn't hear that.
Vitamin C.
Vitamin C. I know that's good for your UTIs.
Vitamin D.
Why vitamin
D for.
So you're thinking about calcium and the D to help with the absorption of calcium. Okay.
And then also fluids.
Okay, fluids. All right. Anything else? Because I think there's, I know high protein. I can't remember it's calories or carbs. I have to go back and check that one. But I know there should be at least two different, or at least two assessments or two foods groups that should be provided. And I don't know if anyone got that far on looking at the osteomyelitis, but yeah, all of the exemplars will be tested. Just kind of FYI. So even if I don't get to them in class, that's why I'm kind of going back to those, and then we'll talk about cellulitis briefly. Or actually, I can pick up cellulitis on Tuesday if that works for you guys outside of the asset base.
That's fine with me.
Because we're winding down to the last 2 minutes. So yes, make sure you know the nutrition of because it's really important for your osteomyelitis patient to make sure that the nutrition is really good. And especially if that, your diabetic patient is a part of that process. So you want to make sure that we're giving them the right things to help promote healing. Okay, we don't want to alleviate that process. But nutrition is a part of a lot of the dietary or a lot of the conditions that we have. But having a balanced nutrition for them would definitely be appropriate. Makes sense?
I'm just wondering why none of my downloaded papers has the FE fistula as one of the exemplars.
It was in. It was supposed to be in your gas exchange. That's where that came from. From the
osteomyelitis?
No, he's asking about TE fistula.
I don't even see osteomyelitis on here.
I don't see that. Yeah, I don't see that too. Like maybe they should be separated. It's telling us of all the exemplars because we're going to miss a few of them now. I've never seen osteomyelitis I've never seen it until now, or the fistula, or even pneumonia.
Hang on, I think I have.
She talked about the fistula. She talked about the fistula in class, Mrs. Prisha did, but osteomyelitis isn't. I don't see osteomyelitis on the immunization.
I'm going back. Hold on. Under the faculty resources, it was added in 2015 under the faculty resources for 1533. So hang on, I'm gonna share the screen so you can see what I'm seeing. So you guys see that? Right here,
Yeah.
and then
Okay.
cellulitis.
Yeah, the osteomyelitis ain't on ours, but the other ones are.
And just recently, Mrs. Hudson, you sent out an email that had the pharmacology breakdown with the exemplars.
Mm-hmm.
The osteomyelitis wasn't on there either.
Okay. But you can see here, well, you see for faculty, that's what it had, no resources.
If you can just, so if there's a way we can just know all the exemplars, so we don't forget anyone or not fail to read them.
Okay.
But,
They probably, Marky, have not updated the pharmacology ones for osteomyelitis, but just understand they'll get, we talked about, I think it was Quinda, and there was another one. Make sure I say it right. That.
Could that email with the pharmacology, with the exemplars be resent out?
Mm-hmm.
when was it sent out?
That was sent out before you guys joined the group, and I have to do a back door in order to send it to you. So I don't mind doing that. I can send it to you guys. It basically goes through, it lists the medicines that you should focus on for your respective exemplar.
Okay.
Thank you.
Thank you.
So I'll send that to you guys, so that way you'll have it as well.
Okay.
So, because I don't have access to the 1324 course, but I do have access to your email via community. So I'll just send it. I send it out in a group. So I send it to my class, and then I have you guys added on as well.
There's a list on community under the J2 tab. If you go down to concepts, it says fall 2017 CBC concept and exemplars distribution, and they're all on there.
Are you talking about the concepts, Jenny, or are you speaking of the pharmacology?
Oh, no, these are the exemplars
Oh, okay.
for each concept.
Okay.
Oh, okay.
And
Okay,
it's updated for 2017, 2018. So
Thank you.
wow.
You said that's under what?
Can I say
go
that
on,
again?
go on community.
Hold
under
on.
the
I'll go
J2
there. Just hang on a second. It'll just be easier if I go there. That way they can see it. All right, so I'm getting ready to share my screen again. All right, so here's community. So yours was ECT nursing. So what Jenny was saying is go over to second semester J2. Semester 2, 2017, 2018. And when you scroll down, is it this one here? The evolve?
The next one down, concepts.
Oh, here we go.
It's the last document on that one.
So fall 17 CBC concepts and exemplar distribution, this one here.
Okay.
And you're actually also able to see them under the level 2 Evolve crosswalk.
Right. So this document should come up, and it pretty much tells you all of the exemplars.
Okay.
So here's and it actually gave you for first semester. Here's second semester here. So here's all of the exemplars that we're going to discuss this semester. So even osteomyelitis is missing here, but this one was added in 2015.
Osteomyelitis is on there.
Oh, there it is. It's under metabolism. I found it. So all of the exemplars are there. I'm trying to see if I come across 1324. What I can do for the 1324 people, because I believe that I have the 1324, I have their exemplars too. I think I saved it to my computer. So when I send out the pharmacology list, then I'll also send that too. Okay. Any other questions from you guys? Well, I hope this has been helping you guys get questions and things, or things that you're not quite understanding. You know, it makes some sense at this point. But try to come with your questions. That way, if you have them, I know somebody else is having them. Okay?
Are you going to do this every Sunday around this time?
I usually do a Saturday or a Sunday. I asked the group, because I was doing them on Saturdays, but I can do them on Sundays at this time. It's not a problem. Or I can do them earlier. I'm cool.
Are you thinking about doing one next?
Well, hang on, there's two people talking at the same time. I need one at a time. What was that?
Are you thinking?
All right.
Go ahead.
I'm waiting. 3 times a charm. Okay, I can barely hear you. Speak up a little bit.
Are you thinking about doing one next week?
I was thinking about doing one next week if you feel you need it. So let
I
me
would love it.
let me tell you let me know on Tuesday if you want one on Sunday, and I'll do it at the same time.
Yes, we do want.
Yes, this is a perfect time.
Yes.
Okay, not a problem.
Thank you so much.
Thank you so much for doing this.
All right.
I have a question before you go.
Okay, go ahead.
About appendicitis. I'm sorry, I couldn't find it anywhere in the reading. What foods do you avoid to? What foods do you need to avoid to prevent you from getting appendicitis? That was one of the questions from the Raising the Bar.
Basically, fiber in your diet and water. What ends up happening as whatever's not used by the small intestines, as it moves through the cecum and it goes to the ascending colon, is basically what they call a fecal lift. It's like basically a poop ball. So when you're constipated, you know, the little balls that drop in the commode and splash back on you, you're like, what the what? It's that.
So when you have appendicitis, you avoid that?
Well, basically eating fiber, drinking your water, and making sure you have regular bowel movements. Regular bowel movements is basically after 30 minutes, after you eat a meal, 30 minutes, you emptying out. If you go once a day, you're at least doing better than people who are going every 2, 3, 4, 5 days. The only folks that should be going 5 days or more are babies that are being breastfed. They only poo every 5 to 7 days. And then as they get more food introduced into their body system, they begin to poo more. However, for an adult, you should be at least going to the restroom once a day. So if you have any grandmothers, you'll see them saying they have to take X-Lax to go to the bathroom. But that's usually what it comes from. Stool gets left behind, waste product gets left behind, and it pretty much starts the inflammatory process for the appendicitis. But yes.
Okay.
That's why I said more fiber and more water in your diet. Okay? Well, that's a good question. Anything else? You guys good? All right. If you're good, then I'm going to stop recording, and then we'll see you guys on Tuesday.
All right, man.
All right.
Thank you so much.
Thank you.
Thank you.
Thank you.
Yeah. Bye, y'all.
Bye.
Have a good
Okay.
evening, everyone. Bye.
You too.
Thank
Bye-bye.
you.
Bye.
Thank you, Miss Hudson.
You're welcome.